Our next speaker is Mr. Fadi Alzayer. It gives me great pleasure to introduce Mr. Fadi. Fadi is the Laboratory Supervisor at King Faisal Specialist Hospital. He is the president of the Arabian Society for Histocompatibility and Immunogenomics. If you are not a member of this society, I sincerely suggest that you contact Fadi or any of our group in ARSHI to join this group. It's very informative. We have organized this course with ARSHI. Fadi is certified by ABHI. He is also a certified manager, certified trainer for Six Sigma. And he trained so many people in Saudi Arabia and around the Middle East. I welcome Mr. Fadi, who will be giving a talk on immunological assessment for transplant candidate, bench to clinic. Mr. Fadi, please.
Thank you, Dr. Ali. I hope my voice is clear. Thank you for giving me this opportunity to talk with this forum. I really appreciate your efforts. My talk will be covering the different immunological aspects that we cover in the laboratory serving kidney transplant programs. And basically, the immunogenicity in organ transplant, we are only tagging the humoral immune response and leaving the cellular immune response aside, as we are in a laboratory in HLA tackling only antibody that attacking the organs. If the principle of that is, if we believe that the antibody make failure, then patients with no antibodies should have a good graft function. And this is really a big study that had been published a while ago showing no antibodies has a good function with about 5 years and 7 years graft survival. The immunogenicity of the organs, we all believe that most of the solid organ transplant happen in the world is basically from mismatch one or more mismatch HLA antigens. Therefore, it will induce immune response toward donor mismatch HLA antigen by producing antibodies. And our job is to detect those antibodies and advise our clinical team. We have to believe that the post-transplant facts in which more than 60% of late kidney graft loss are due to antibody-mediated injury. In addition to that, in the absence of DSA, most likely we will see a good graft function with 1 to 6% only of those will develop AMR. In the presence of donor-specific antibody, 21 to 55% will develop antibody-mediated rejections. At our laboratories, or at most of the HLA laboratories worldwide, we are assessing the graft prior to transplant through performing 3 techniques: HLA typing, cross-matching, and there are 2 methodologies for the cross-match, CDC or flow cytometry, as well as HLA antibody detection that my colleague Dr. Awaji mentioned in last talk. The method aim, when we need to understand what is the aim of the technique that we do. When we do HLA timing, we are aiming to determine the degree of compatibility between 2 different individuals. When we do cross-matching, it is basically an in vitro transplant, and that is to assess the recipient immune response versus donor HLA antigens to evaluate the risk for the transplantation in vitro. And the third technique that we do is antibody identification, and that is to determine the presence or absence of the significance of that HLA antibody targeted to the donor antigens. The point one regarding the HLA matching is we need to understand the difference between solid organ transplant versus stem cell transplant, in which the directionality of HLA matching in solid organ transplant, we look at host versus graft, versus in stem cell transplant, most likely we look graft versus host. So in this, just a small explanation that if the recipient is A11, A30, B7, B35, and the donor is only homozygous at A, which is A11, B35, so the recipient will not recognize any foreign antigen. In that, we consider this as a zero mismatch. So there is no any mismatch, there is no anything, there is no immunogenicity of any HLA antigens. In this another cartoons here, you see the donor mismatch antigens are 3 mismatch, and the total antigen type in this example 6. So we can say in this example that the mismatch is 3 out of 6 antigen mismatch. So the patient will, if the patient have antibody, the most important we will focus on is A32, B51, and B53. Some of the people also are in the transplant immunologists, when they say haploidentical, and when we say about haploidentical, we mean that it is 50% match, and 50% match usually it is haploidentical, in which this example as 4 out of 8, as you can see in this slide. There are different HLA typing methodologies applied in the laboratories, and all of the techniques are excellent, but it depends, utilizing these techniques, it depends on the throughput of the laboratory, it depends on the clinical program that the laboratory is serving. So choosing the program need to know what it's going to be used for. One of the technique that is commonly used worldwide in most of the laboratories is RSSOP, or reverse sequence specific oligonucleotide probe, that is performed in Luminex instrument. This is suitable for medium to high throughput laboratories, but also one of the disadvantages of this is probably the limitation of the resolution. Clinical program who serve unrelated stem cell transplant program, this methodology might not be really the best to be used in a laboratory. Another technique that can be used in a laboratory is real-time PCR. It is a very fast technique. It is very useful and suitable for deceased donor transplant program, in which you can finish the typing within like 90 minutes. The third technique, which is nowadays is coming since a few years back, and most of the laboratory now utilizing it, is next generation sequencing. This is really an excellent technology that you can type and across the gene. As yesterday, I think Dr. Rabab mentioned that you can sequence from exon 1 to exon 8, and it is for high throughput laboratory with higher resolution output. The fourth technique can be used also is SSP, sequence specific primer. It might be appropriate for low throughput laboratory, 1 to 10 to 15 a day, but again, the resolution is one of the limitations. I might just tackle one of the technique, which is next generation sequencing. There are different companies that serving these techniques, and these techniques analyzing these techniques, usually utilizing or using two type of algorithms. Some of the companies apply two algorithms, some of the companies apply only utilizing one of the algorithm. One of the algorithm they use to analyze next generation sequencing called consensus algorithm or de novo assembly, in which you need to, when you amplify your PCR or the DNA of the patients, you just need to cut it to small pieces, okay? And then you can assemble all those DNA fragments without having a template to look at until you form the picture, until you form the assemble of that fragments. That called consensus algorithm. Some of the companies using this one. Another companies utilize another type of algorithm called statistical algorithm or mapping assembly, in which you have a reference picture, and then when you cut your DNA, you can assemble that by looking at your reference. And the end over of this technique is high resolution typing. This is very suitable technique for unrelated stem cell transplant, as well as now high resolution is really positive impact in solid organ transplantation. HLA matching, when we talk about HLA matching, yes, we understand and we perform a lot of solid organ transplant between mismatched individual. We do understand that you can do a transplant for solid organ without full HLA match. However, more match, better graft survival, and less immunosuppressive regimen could be. And also, as you can see, this is a big slide that states if you have more mismatch, less graft survival percentage, as you can see from the CTS study. The second technique that I will tackle in a quickly few minutes about cross-matching. The cross-matching is we would like to assess in vitro the immune response of the recipient against the donor HLA antigens. And basically, I usually call it in vitro transplantation, in which you can relay what's going to happen in vivo proactive prior transplantation. There are mainly two techniques performed in the laboratory: CDC, which is abbreviated by complement-dependent cytotoxicity, and another one, flow cytometry. CDC is the basic technique that has been developed by Paul Trozaki a while ago, and as my colleague Dr. Mohammed mentioned in his presentation, flow cytometry is the probably 100 times more sensitive than CDC technique. Again, this slides is explain the importance of applying CDC cross-match. But what I would like to tackle in this slide is the relevancy and sensitivity, in which you have a couple of cases who were positive CDC cross-match and no rejection, that tell us that those positive cases that were irrelevant. So in order now, if we believe that those cases were irrelevant, then we need to understand what is relevant. Also, as you can see, there are a couple of cases where completely negative CDC cross-match and no rejection episode happened. It tells us that there is lack of sensitivity of this technique. CDC cross-match is, yes, we do believe that it is least sensitive because it only can detect high titer antibody, can't detect weak antibodies. Another thing, only it can detect complement fixing antibodies. So non-complement fixing antibodies might not be able to be detected. Therefore, the decision from this technique is probably when it is positive, it is a case to tell you to rule out the patient from transplant rather than to tell you proceed for a transplant if it's negative. So any laboratory who bent their decision for transplant based on negative CDC, that might be a risk. And I understand and I respect probably the European school, they apply CDC more than flow-based technique nowadays. Why we need to change from CDC to flow cytometry? It's only detect complement fixing, it's only detect strong antibody, and it is subjective techniques in which if I am not expert in interpretation of that technique, I might call the case negative or doubtful positive, and my colleague, if he is very expert, he might call. So there is a different opinion in the interpretation if the person is not expert in interpretation of this technique. Another one is the flow cytometry. From its word, if we dissect it, flow mean continuously moving, cyto means cell, meter mean measurement. So if we put three words together, we are measuring continuously moving cells. And those cells will pass through the laser, as you can see in this slides, and the laser will tell us which type of cells we are dealing with and if there is any antibody bind to those cells, with very sensitive as these cells pass by laser one by another one, so we can digitally analyze the case properly. The technique of this the technique is very simple. We isolate the donor cells and then we mix it with a patient serum. We leave it for a while, give it time for the receive if there is an antibody, bind to the donor cells, and then we tag the B cell with CD19 and we tag the T cell with CD3. We add the secondary antibody that is attached with the fluorochrome. If there is any primary antibody bind to the cells, it will bind and it will give you more fluorescence. One of the very important is cell specificity. Probably one of the also weaknesses in the CDC cross-match is B cell isolation in CDC cross-match is one of the challenges. B cell is very fragile cells, and most of the laboratory historically do CDC for T cell, in which we might not be able to detect class 2 antibodies. However, in flow you can. On the other hand, B cell, as you can see in this cartoon, it expresses HLA and non-HLA. Having non-HLA molecule in B cells making the cross-match less specific. Therefore, in order for us to increase specificity as well as sensitivity of flow cross-match, we have to remove non-HLA markers, as you can see on the B cells here. So, one of it is FC receptor that is expressed on the B cell. So we need to block or remove those receptors and leave only HLA molecule to increase our sensitivity of the assay. Therefore, we use enzyme called pronase. This is a prolytic enzyme that targeted FC receptor, mainly CD20, to remove those and leave the HLA, in which by applying that, it will increase your sensitivity. But again, also, we have to understand the concentration and the time of using this enzyme. It has to be adjusted and QC very, very well. I'm not going to go deeply on the technical aspects of how to use the Pronase. The interpretation of this technique is not usually subjective based on what you see of cell death or life, but it is based on channel shift, how far or how distinct your reaction of the cross-match between the donor cell and recipient serum with the negative, how far from the negative control. Usually it is interpreted based on something called median channel shift, how much channel shift away from your negative control. And that need to be standardized very, very well and very careful, because our clinicians solely depend on what we say. And usually we, as a human being, we do believe on these numbers, how far it is, like 60 channel shift, 100 channel shift. And I think giving interpretation for more than 200 channel shift, the clinician should be very, very careful considering that. There are only 4 paradigms if we think about antibody and cross-match. As my colleague Muhammad mentioned in his talk, the importance of the antibody. A cross-match cannot be interpreted alone without looking at antibody, and also the antibody people who, the antibody testing person might not understand the relevance of that antibody without doing a cross-match. So basically there are 4 algorithms that we see in the lab. There is no more than that. If there is antibody negative, cross-match negative, this is really logic and there is no brain to use that. Brain to think about it. Another one is antibody positive, cross-match positive. This is only can be happen if that antibody is donor specific antibody. Third and fourth scenario, you might see a cross-match positive and antibody negative. This need to be looked at now, because, and I will explain it in next slide. Another fourth scenario, you might see cross-match negative with antibody positive. This is a lot of happening if the patient is sensitized without the presence of donor-specific antibody. So you might see the cross-match is negative and proceed with a transplant. We need always, when we do a cross-match in a laboratory, we need to know the relevancy justification if it is positive. Every cross-match, we need to justify it. Is there a reason for it to be a positive or not? Not every positive cross-match is relevant or significant. Now, if the positive cross-match, if it's positive cross-match, we need to ask ourselves, is the patient sensitized or not? If the patient is not sensitized and the cross-match is positive, then we need to communicate with our clinical team and ask him, does the patient has autoimmune disease like SLE or receiving any therapeutic drug like rituximab or IVIG, because both of those impact give false positive reactivity. And if the patient is sensitized, then we need to understand, is there a donor-specific antibody or not? That will really make your cross-match justifiable. In order to assist the patient, we need to fit the puzzle together between the person, the typing, the cross-match, as well as antibody identifications. I will go just a few more slides about the interpretation scenarios of a cross-match that we are seeing in a laboratory. If you have a flow cross-match positive T cell and B cell, usually the interpretation should be most likely due to class 1 antibody and maybe class 2 antibody. When we can change maybe to should to must be class 2 antibody is if we do antibody identification for class 2 and there is donor specific antibody class 2, then we can say that this cross match is due to class 1 and class 2. Scenario 2, you might see negative T cell and positive B cell, and that might be due to low titer class 1 because the T cell was negative and the B cell absorb and pick up the class 1, as well as it could be due to class 2 antibodies. So that might be the scenario number 2. Scenario number 3 is T cell positive and B cell negative, most likely due to non-HLA antibody, as the B cell is negative and it is express HLA molecule. However, I would like to also to emphasize in this, there are a couple of studies and showing this type of phenomenon, particularly if the antibody, some of it says C locus and some of it pick up by the C, pick up by the T and the B. But usually we should not see routinely that, like this type of algorithm or this type of scenario, sorry. Negative CDC, it's either the patient is sensitized but no donor-specific antibody, and you might see negative cross-match, or the patient is negative PRA, which is straightforward to proceed with a transplant. I will not have much of the cases to present here, but I will share with you only 2 simple cases how we interpret usually the cases. This is the HLA typing, and in this case, the donor is full HLA mismatch, 10 mismatch with his recipient, and he was sensitized class 1, negative class 2. Then the next step, we need to do antibody identification. As you can see, he's broadly sensitized, and these are, he has a donor-specific antibody against all of the mismatched HLA class 1. So if you do cross-match, and I'm sure you know the answer before I show it in next slide, in which you expect presence of DSA with a lot of mismatch, high MFI, we expect that the T will be positive, the B will be positive, and why is that? Is because class 1 donor-specific antibody. Another example is, as you can see, there is a 5 mismatch in this case, which is A3, B55, C16, DR8, and DR3 here. So there is 5 mismatch. PRA or antibody identification for this case was completely negative. When we do flow cross-match, for this case, it was positive B cell, negative T cell. And we should not expect to see positive cross-match. Patient is not sensitized. So why that is positive? Here is the case, as I mentioned in the last slides, that we need to justify the relevancy of this positivity. What we need to do next? We need, of course, it will be good to communicate with your clinical people and check, does the patient has autoimmune disease? You can check the NA profile for that patient. He might have SLE. And then we do auto-cross match. That auto-cross match will tell you if the patient have antibody against himself. And when we say against himself, that antibody will not against the HLA molecule, but it will be against another marker expressed on the lymphocytes. And this is a case that when we did, the T was negative, the B was positive, the interpretation will be positive cross-match is not significant and most likely due to antibody autoreactivity. At our institutions now, we apply different, our protocol of testing is we do HLA typing to assess matching level between the recipient and the donor. If the HLA mismatch 6 out of 8 or more, or if the class 2, 3 out of 4 class 2 mismatch or more, then the patient, we don't proceed with completely direct living related. We direct that patient to the pair kidney exchange program to avoid the transplant patient with more mismatch. Another scenario, so if the degree of match 3 antigen or more, so that means if the matching is better, then we do PRA screen. If it's negative, then we transplant. If it's positive, we need to identify, is there a donor-specific antibody or not? If there is no DSA, then we transplant. And then if there is a DSA, and if that DSA less than 2,500 MFI, we do initial cross-match usually. And if it's negative, we transplant from that intended donor. If the DSA more than 2,500 MFI, we usually do initial cross-match. And if it's negative, we transplant, because sometimes you might see donor-specific antibody very weak that lead to negative cross-match. You can start straight ahead to proceed with transplant with, of course, some of the induction like low-dose IVIG or rituximab, as well as if you have initial cross-match is positive, then the patient will be referred to kidney pair donation. That's my talk, and I would happy to receive any questions.
Thank you so much, Mr. Fadi. Any question, please?